So welcome to the webinar, Mastering the Arch, Edentulous and Denture Scanning. The lecture will be presented by Yen Pinheiro, RDA, CDD, and Kelly Bevington, and we will begin shortly. And with that, it is my pleasure to introduce Kelly Bevington, Director of Intraoral Technology. She began her career more than 20 years ago as an RDA EFDA, graduating from Ryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the MDX clinical iOS training team and has clinically trained over 2,500 dentists and their teams. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And we have Yen Pinheiro, RDA, CDD, Dexis iOS Solution Specialist. Yen is Digital Solution Specialist the solution specialist at Dexis, who got a little tongue-tied, helping dental teams confidently adopt digital technology. With more than 30 years of chairside experience and more than 20 years in digital dentistry and intraoral scanning, she makes workflows practical, efficient, and achievable, bridging clinical reality with modern innovation. And with that, I get to say, take it away, ladies.
Thank you so much, Jessica. We appreciate you getting everything kicked off. All right, Yen, you ready to roll?
Ready to roll.
Okay. So thank you, everybody, for being here tonight. We appreciate you. Just a few disclosures from a financial standpoint. We are not financially reimbursed by anybody outside of the companies we work for, which is National Dentex and Envista. As well as the program itself is not receiving financial support from any commercial organization. So I know it's probably been a while since you signed up for the course, so I always like to review our learning objectives, right? And what our goal is to provide to you this evening. So we're going to review how best to identify essential soft tissue landmarks and software indicators required for predictable edentulous denture scanning. Yen is going to demonstrate or show you an example of a 360-degree denture scan. We're going to provide you some helpful scanning techniques to offer soft tissue stability and some different tools that you can use to do that. And then lastly will be to evaluate some scan data using software validation tools to ensure accuracy and that it's really ready to go to the lab.
Mastering the arch. It's time to get started. So this is one of the ones that we get lots of questions for. We want to know the workflow, what goes first, what goes second, in what order. And we always say, Kelly, we should always have a conversation with our lab, right? Because it's a team
Absolutely.
effort, and there's so many scenarios, so many. But I want you guys to look at this screen and see that within the software, there's only 3 pages that you can possibly use. You might use all 3, you might not, but there's just 3 pages. There's the common scan, which is when the patient comes in the chair, and you're gonna collect the data, what's in their mouth. It would be the existing denture. And then there's the edentulous scan page, where you would collect your soft tissue data. And then the denture scan page is a page where you can do the 360 and be able to take all 3 scans and match them and align them within the software.
Yeah, and I do have a question in regards to the matching. So does that happen automatically, or is a bite registration required for the matching to occur?
Well, we would already have the bite registration in the common scan. And then
in the common scan. Very good.
And then when you click on the button, it auto matches for you.
Perfect. Sorry, I'm fighting with that new cursor I did.
Yeah. So, we always mention this again because the Edentulous arch is the most challenging canvas in digital dentistry. But today, Kelly and I, we're going to master the tools that make capturing it predictable.
Love it.
Yeah. So beyond the impression, we really try to make it simple. It's so much information that we want to provide. But at the end of the day, we're taking 2 scans. It's either going to be a soft tissue scan or a denture scan.
Is there ever an example when you would do both?
Yeah.
Okay.
Yep. There is. So here's some tips when we scan edentulous soft tissue. If the software has AI, you want to turn it off. And the reason being is because the AI loves to clean everything up for you, right? Because we don't have to trim our models anymore. But when the AI does that, it's going to maybe remove some valuable tissue that you really need for your denture design. So when we scan, it's so important to know that with the scanner, it actually can go in the speed that you go. So when we're challenging or we need to stretch a little bit or we need a little bit more control, do be comfortable and slow it down because we want to get some really nice, clean, accurate data. So you want to keep a small distance from the scanner tip to the soft tissue, especially in the lower jaw, because then you start to collect the floor and the sides of the mouth or the cheek. You want to dry the mouth as much as possible. You just don't want any saliva bubbles and stuff that's going to interfere and reflect when you collect data. And it's so important to try to scan as much as possible in one singular scan pass. Because as we move back and forth, the soft tissue will move and create different reference points. And that is where the scanner freezes and we struggle. Kelly, is that universal, you say, with all scanners on the market?
Yeah, I really would. I was going to reiterate the fact about the speed. It is really important to go slower than you would on natural dentition, right?
Yeah.
Like we're used to wanting to go fast, fast, fast when scanning actual teeth. And with soft tissue, you do want to go slower. You want to be more deliberate about the scan path that you're taking as well, I think, to prevent that lagging or freezing with most all scanners out there. Because as you mentioned, the soft tissue is mobile. And when it moves, then the scanner is struggling to stitch it together and recognize the reference points that you've already captured.
Yeah. So for better alignment, I have 2 tricks. On the lower jaw, I always make sure we have a nice buccal frenum. And for the upper, I like the palate as a reference. And again, all cases will be different, but those are just some tips.
I like it.
Yeah. All right. So here's an example. We are now in the Edentulous page. And as you can see, there's actually a scan path. And it's so important to follow the scan path because it's what keeps us on track, keeps us going in a forward motion, and we don't over collect data and we don't get frustrated. So the first scan is always going to be straight occlusal first. After that, we're going to get the hard surface, the palate, in a zigzag motion from the anterior to the posterior most. And then we're going to roll to the distal and we're going to collect one side, the left, and then the right in any order that you want. And you can retract in different ways, but you don't want to pull the tissue back too hard. You just want to hold it in place as you collect your data. And Kelly, when we get into the further into it, she'll go over some tools and stuff that we can use when we're in that arena.
Yes.
And the next one. So you know us, we love to give you some tips and tricks. And I like it sometimes, Kelly, when I have a sidekick with me in the room.
I do too. I do too.
Dental, it's funny, as dental assistants, we don't have a dental assistant to assist us, right?
Right.
We're expected to do everything ourselves, right? We're just magical. But if I did have someone in the room to help me. The dual technique is a lovely one when one person manages the soft tissue, holds it in place, while the other one just has to pay attention to the data collection. And we're going to say it one more time, the golden rule. You really want to aim for one continuous movement, and you slow down as needed. Precision is everything. We want nice, clean data. And with the software real-time sync, it's valuable to know, because they're all different, that as you collect your data, the live view that you see is what you're going to get. So that ensures that you have good data, accurate scans on the first pass. You don't have to stop and look. You already can see it in real time.
Right. And so if I recall correctly, there's no like post-processing that needs to occur to see that real-time scan. It is what you see on the screen. Is that correct?
That is 100% correct.
Got it.
So we talked about the common scan. We talked about the edentulous soft tissue scan. And now we're at the denture scan, which, Kelly, is the 360 scan of the denture. And even in the denture scan, we do give you a path to follow for accuracy, for the data collection, and ease of use. Every scan will have a different path that it likes and is comfortable with, and it's important to follow the one that you're using. And with us, we have the 4 swipes that we will utilize when we collect the 360 scan.
Next.
Yep. All right. So what happens after we collect our data? We are able to superimpose all the views automatically. What does that mean? When we go ahead and click on the matching, it'll superimpose the common scan, the edentulous scan, and the denture scan. And you're able to toggle back and forth for the opacity, and you're able to view them individually too if you wanted to. Questions? What do you think about that, Kelly? Do you think people really use that quite often?
I'm not sure. I mean, I like to think that people do. Sometimes I think they do it just in front of us, though, and they hasn't been integrated as a real habit.
Yeah. Sometimes I think they just like to see the layers. Ooh, look at the soft tissue. Ooh,
Yeah.
I mean,
look at that. I think it's really cool how it matches and merges together.
Yeah. Okay. So like I said, we have the auto matching. So it automatically matches it for you. But if you needed to, you can also do the point-based matching. And that allows us the flexibility to be able to separate them and put them together as we like. I see your cursor.
It's not doing what I wanted to do.
Oh, it'll get, yeah.
There we go.
And here's an example when we have the matching and we're able to cross-section and be able to slice through and see. This was really cool that I kind of liked. And I was like, oh, what is it doing? And I'm like, okay. So as you can see on the right side, where you can see that it's binding from the soft tissue to the denture. And then I said, oh, that reminds me of PIP paste. Do you remember that, Kelly?
Yes,
PIP paste?
I sure do.
Yes, where marks where it needs to be adjusted. Well, this is the PIP paste in the digital world. It can show you that, and it can also show you where there's gaps and where it needs to be relined. You know, people always ask, Kelly, so I thought it was important to show what the lab actually sees. But they always ask, how do I collect the edentulous, with vertical dimension? They just can't see what actually happens. And this image is everything because it shows you how, if you picture the denture in the mouth, that is the vertical dimension. And
Right.
all we did was remove the denture, and the edentulous arena is open in space. It's really cool to see. Yeah. So, like we said, there's so many scenarios. So we thought it would be nice to talk about different scenarios. Well, what about a denture workflow for our first denture, right? We did say that you're not always going to use all 3 scan pages. You might and you might not. Well, this is one of the instances where all we used was a soft tissue scan. That's all we did was an edentulous scan. So for the first visit, we would go ahead and collect the edentulous arena. We would send it to the lab, and then we would get back from the lab a bite block or something of that nature. We would adjust, verifying the mouth, and we can collect that data and then send that to the lab.
So in this particular scenario, the edentulous scan you could think of as an alternate,
Correct.
right?
To
Your
create
preliminary impression.
to create a custom tray or a
Yep.
bite block.
Yep. My vote would always be for a bite block. And then probably to take a wash impression inside of the bite block and
Correct.
a 360 scan of that
Yes.
to save you some chair time and an additional 1 to 2 appointments.
So there's so many ways to do things, like I said, but again, we just want to give you examples. So in this instance, the patient sat down, they got the soft tissue scan edentulous. It got sent to the lab. You've seen the bite block come back. They established the vertical dimension, the video. They have taken another wash impression, and they sent it for fabrication. And then you get a printed model or appliance to try in the mouth. 6 steps.
I like it. That's a great slide.
Yeah. And this is the denture workflow reline. I think this is probably the one that I would start with first. I think it's simple. It's just one scan. You send it to the lab, you get a denture back. All right, the next 2 slides are going to be similar. It's a denture workflow, reline denture or partial denture. And it's just the way that they did it in a little bit of a different sequence. With this one, they took the impression and then they captured the video, and then they scanned the edentulous, then they did the matching, then they sent to the lab, and then they had the denture try-in.
So with this one, the wash impression, it wasn't as though the existing denture was being relined and returned for insertion. It was really just being used as a like a reference denture tray kind of situation.
Yes. Yeah.
Which I will touch on as well. And that's
Yes.
probably my favorite technique.
Yeah. Yeah. Yep. Me too. And this one is just with the partial arena. Same thing. They scanned it in the mouth. They scanned the appliance with the reline in it. So that's the additional scan in that one. And then the edentulous, the matching, fabrication, and try-in.
Very good. And as we're going along, please feel free to pop into the chat any questions that you might have.
And that's me.
That's Yen. That's Yen.
That's me. Thank you so
Otherwise
much,
known
everybody.
as the Dex's Queen out there.
Yeah, thank you. And then now Kelly's going to show us what it actually looks like, what all this actually looks like.
Well, when we sort of put it all together, right? Like
Yeah.
different options that we have with scanners that now can finally successfully, with repetition, scan the intraoral cavity, right? Like that was a big deal. We've been scanning for what, 18, 20 years. I have anyway. But denture scans have really taken a forefront, I would say, in the last probably 3 years, probably because of, demand. The doctors demanded it, right? You invest into a piece of equipment and you want to be able to use it for everything. And thank goodness the scanner manufacturers like Envista recognized that and made alterations to their own systems to be able to do it and do it well. So what I'm going to focus on a bit is what you can do with those scans. And so we divide it into a few different options. One is a copy denture, which is an exact copy of an existing denture. So imagine, Mrs. Jones comes in and she's going to winter in Florida and she loves her denture and she wants an exact copy of it. That's what a copy denture is. And you could easily do that 360 scan that Yen mentioned. You wouldn't even need to scan the intraoral cavity, right? So that one's very, very easy. The immediate denture is typically very easy because there's some existing dentition that we are going to make an immediate denture, right? And it'll be a healing denture, and we might do a reference denture technique on it, maybe 3 months later. But immediate dentures are also very easy and successful to scan. And then lastly is the reference denture, and the reference denture is my personal favorite, and I've got some slides here on it. But think of taking that existing denture and using it to be the best custom tray you'll ever have. So oftentimes I find doctors are like, oh yeah, no, I don't want to use that old denture. It's terrible. It doesn't fit. Aesthetically, the patient's not happy with it. I was like, does it fit well enough? Does it fit as good as a custom tray? Oh, well, yeah, sure. Well, then we're going to use it as a custom tray. And we'll get into that. The other is scanning that edentulous intraoral cavity, which Yen, you mentioned. This is a little tool. Sometimes these little tips we come up with. So Dr. Thompson transfer sticks. I don't necessarily do the 3 dots on the palate. If this is the palate and this is a rugae, I will mark with some X's the post-dam area, right? The post-palatine seal. And maybe do a little Christmas tree on the top of the palate. And the only reason I do that is for my own eyes to digest the information. So we talked about maintaining a scan path. And sometimes with a fully edentulous patient, especially when you're new to scanning, it's a lot of pink soft tissue and you're not 100% confident in which direction to go. Do I need to go more posteriorly? Do I need to go left or right? So if you have some markings, it can assist you in doing that. We also, Yen mentioned about the duo assistance, right? Or imploring four-handed dentistry for those fully edentulous scans. So if you can imagine most offices have tongue depressors, right? You would have one assistant with the tongue depressors retracting the lips and cheeks, or perhaps we're going to use the ScanMate. It's an autoclavable device. It comes in the baby blue as well as black, which is really nice for scanning because it's completely anti-reflective, or a plastic mirror. Plastic mirrors, if you have them in the practice, it works really well. What we want to avoid are metal cheek retractors. They're typically really horrible with scanners. The light reflection off the metal can cause issues, to say the least. And then the Optrogate, I have the backside of it here, but I don't know if anybody has used the Optrogates before. Sometimes it depends on the patient. Sometimes they're really helpful in retracting the lips and cheeks until you get to the buccal vestibules, and then it can get a little cumbersome. And that, again, is where bringing another person or imploring four-handed dentistry can be helpful. And I'm always excited to learn about other techniques that people have success with. So if you're sitting there thinking, oh, well, I like this better, pop it into the chat so we can all learn together. That would be great. And Yen mentioned earlier, you want to make sure that the intraoral cavity is very dry, that there are no saliva bubbles. So, 2x2s are going to be your friend. And physically wipe off the gingiva, wipe off the tissue before you start to scan intraorally. When you are scanning the denture itself, we're going to go into a little bit of a different technique then. But remember to try to hold the denture in your non-dominant hand and use your dominant hand that's holding the wand to move. Oftentimes people want to put the denture down on a countertop and try to scan it that way. I've tried it. I wish you luck. I have not seen that to be successful. And last but not least, keep that slow, steady, sort of continuous pattern. And we say slow to start off, but truly you will become faster and faster as you get more accustomed to it. And that's fine as long as the images are stitching together. So this is the reference denture, right? The maxillary dentures cleaned out. You want to make sure that any reline material or paste or anything is removed from the denture. The occlusion can be worn, as I mentioned. It doesn't have to be aesthetically pleasing because we're really using it as a tray. And here is a good tip. You want to apply adhesive, so tray adhesive to the intaglio of the denture itself to allow that impression material to adhere and stick so that you can scan it appropriately. Oftentimes people are a little hesitant about doing that, but I will tell you that if the material starts to like break away from the denture itself, it's no longer accurate, right? That material is moving. So it's important to use the tray adhesive. And how you would remove it is with isopropyl alcohol and a good stiff denture brush, and that removes that tray adhesive after you peel out the impression material. So this is a great image of a heavier body material being used specifically for the border molding. So we're going to border mold it first, place it in the patient's mouth, do your phonetics, do your muscle toning like you ordinarily would with a traditional custom tray. Remove that. Do any trimming that might be necessary on the buccal. You can see the blade in the upper left-hand corner. What you want to avoid is that material completely covering the buccal surfaces of the denture, because when we put it back in the mouth to take a bite registration, we want it to connect, right? We want it to match together. And here's an example with that light body. So border molding is here in the middle, and then the light body wash is last, and it's off to the right-hand side. The thing that I really like about it also is that at the end, you're peeling out that impression material and giving your patient back their teeth, right? So they're never without their denture. And that is, quite a big deal for many patients. And what could be next? So typically it is going to be some sort of a try-in. On occasion, we can do directly to finish, but I don't necessarily recommend that. I prefer a printed try-in. And this is what one looks like if you have not seen it before. I've got a handy dandy one here as well. I don't know how well you can see it, but I like to show it. It's a little offsetting the first time you open a case box. Like I was like, oh my gosh, when I opened this, I was not expecting it to be monolithic out of, one continuous print. What's really cool about this is you can You can mark the occlusion, you can adjust the occlusion with the burr, you can communicate back to the lab about, placing of the teeth differently. Maybe you want to bring out the buccal corridor or rotate a lateral or shift the midline. Any of that can still be done at this point in the process. And this is an example of what that try-in looks like, how it's designed. And if we think about the try-in, a printed try-in versus a wax try-in, I do want to address that quickly. Is you can still, from a digital scan, you can still do a wax try-in. You can do a traditional try-in. That's not a problem for I'm sure, any lab. I know it's not for us. What I like about the functional try-in is the patient could actually leave with it for a couple days. They can speak, they can try to chew their favorite food, get buy-in from their loved one. And it's an accurate representation as to what that final denture would be. Not that you can't make alterations, you can. Whereas with the wax try-in, it's usually an issue for the patient that it doesn't fit, and they're sort of like crossing their fingers and hoping that the final will fit. So I like to just mention that to people. And then again, as dentist, do you like to sort of put your fingerprint on a try-in and get the wax instrument and the Bunsen burner out and make some adjustments to the wax try-in yourself? Is that important to you? If it is, then you should probably stay with wax. If it isn't something you necessarily do, then I would encourage you to try a printed try-in. So back to design. And then the dentures themselves are printed in two separate pieces. The base, the pink, is printed separately than the teeth themselves. I just think this is so cool. If you have an opportunity to go and see this, it's really a neat experience. And then they are chemically adhered together, the teeth and the base. And then that is your final digital denture.